morning. Uh, as Dr. Salim said, I think when we talk about communication skills and when we are going to talk very uniquely about emergency department, I thought it's important that we sort of have an overview of patient's journey through our department, and then pick up on some of those points where communication becomes important. So, all the 10 minutes, what I'm going to do is talk about a few sort of concepts of communication which are important in emergency department, and give you some tips on how you can make it more efficient. So let's look at a patient's journey. Any of our patient who comes to emergency. So if you think about it, the patient has multiple encounters. He first sort of comes with a paramedic or by himself. Then there's a triage. Then they goes to a first emergency physician sees them. There might be nurses involved, there might be doctors involved, and then, especially in our department, the second doctor who sees them might be different. And then they have other specialities. Then they might have they might be bounced back to you, but it might be a different doctor. Now, looking at this patient's experience, when he goes out of the CD, it's a collective experience of all these encounters. And when he asked him how did he feel, it's very sort of easy for him to say it has not been good. It's just one of those encounters was not good. And if you look at it from a doctor's your and mine perspective, each of one patient care might involve communicating with that patient, his family, other specialties, radiographers, nurses. So, it's all about communication. And earlier Dr. Salim said, we think it's not important, or at least it's not perceived as clinical. But if you look at literature, rudeness or bad communication has been proven to be iatrogenic. It's one of a common cause of complaints, we all know that, but it definitely is a common cause of poor patient outcome, mortality, morbidity, everything is worse when the communication is not good. So, now, just let's look at why it is unique in ED. Right. It's unique in every way. If you think about a patient, he is there not on his best day. He's there not by choice. It's usually an accident. It's usually an unplanned visit. They're anxious. They are in pain. Or it could be they're embarrassed. They are coming to come and talk to you about something which they would prefer not to talk to anybody. All these things make them not at their best. And when you're not at their best, it's bad communication. When you're angry, you're not at best, you're impatient. So that's a poor start for a patient itself. Now think about the environment. Every literature they talk to you about sitting the patient at eye level opposite your table, but ED, you don't have the choices. It's busy, the privacy is not there. You're going to talk to somebody about their sexual history behind a curtain, 3 sides there are other patients, there are people. So it's not ideal. And from a doctor's perspective, you're busy, you're interrupted multiple times, you're probably hungry, you're on the bathroom. Again, it's your 5th shift in that week. Again, you're not at your best. But for more or less everyone in this room, that's going to be the same for all of our life. And I think we really need to work around how to still do our best in all these circumstances. So, some general rules. Some of these are what we learned as a child, what our parents taught us. Be nice, first of all. If you are nice to somebody, it's very, very likely they'll accept what you say. It's more likely they will work with you rather than work for you, and the benefits are best. Be it the patient, be the other specialty doctor whom you want to refer your patient to. So the first rule, be nice to them and work with them rather than work for them if you look at patient's concept. The other concept, which sometimes is important for us, is being authoritative or being assertive, would be probably the right term. And this is important in some scenarios, especially like, for example, if you're team leading a research scenario, there's not much leeway for debate there, but and you really have to learn to be assertive when needed. And that actually is completely different from being rude. So being assertive is, so don't take it like as the same thing. You really have to master the skill of assertiveness. Now, being assertive also takes preparation in terms of improving your credentials among your team member, and obviously that's something which you have to develop over some time. Now, state facts only. I had to put this on because a lot of times we see people. One, you got to state facts. You got to tell the patient or tell others what actually is it, because they have the right of information about their own care. The other thing is you got to state only what is true. Please do not exaggerate or even don't underplay things either. It's much easier to tell a patient, well, you might be waiting for 18 hours, and then your argument would be, yeah, if they get out in 10 hours, that's a bonus. But I don't think that is true, because as a professional, I think what you say has to be credible. Sorry. Similar way, don't overplay it with your specialties, because again, it's not a one-off thing. You got to do it again. The other one of my big bugbears in Hammer, like our hospital, it happens everywhere, is we stereotype people. I'm sure you all know about, they're talking about, oh, he's a Bengali, he's an Egyptian. I'll tell you my story. I mean, I came to Hamad about 3.5 years ago. One of my first shifts in male C&3. I was sitting in one of the front cubicles, and I saw this guy in a lot of pain. I wrote morphine, 5 milligrams or 10 milligrams, I can't remember. Those days I used to sort of write more morphine than diclofenac. And the nurse looked at me in sort of a disapproved way. It's like I was not sure what it was. I walked out of the cubicle and asked her, what's the problem? She said, he's a Bengali. Honestly, I was thinking, what have I done wrong? It's like, is our Bengalis allergic to morphine? I don't know. I was like, I didn't understand it. And then I asked her, what's the problem? And she said, well, they overplay their pain. So, but now so I can see where that came from, because it's very, very common. Why I'm saying that in the communication station is, before you walk into a patient's cubicle, if you are biased already, that's a poor start. I'm not just talking about bias on the basis of race, gender, or anything. Even if it's that patient who's come 48 times with chest pain, and every time he's been discharged saying, there's nothing wrong with him. If you go with a preset agenda, oh, I'm going to see him and just tell him off, that conversation is not going to go very well. So just avoid having a preset thing. And then keep your conversations patient focused. Now, why I say this? If it's not about your stand versus the other person's stand, especially in conflicts, or even with the patient, if you have an agenda saying, oh, this guy doesn't need a CT and I'm not going to do it, and if that is your first thing, and if that is your position, then that communication is not going to get very well. The same thing with referral. Unless you think this patient needs to go under medicine, and if you're not going to listen to the other person, then that communication is not going to go very well. Change your perspective, thinking, what is this patient's interest, or what is in this patient's best interest? And if you work towards that, I think it's much easier to negotiate. So, just dwelling on the same point which I was talking about, it's all about patient-centered care. We all talk about evidence-based medicine. What's evidence-based medicine? Anyone who can sort of remember the definition? Okay. We all think it says most current evidence, but there's a last bit to that, which is in the best interest of the patient's views and needs. which is something which we sometimes tend to ignore. So actually, good evidence-based medicine is the junction which is scientifically correct, is in the patient's best interest, or is in the meets the patient's views and expectations. So it's important, if you have to practice good medicine, we need to find that bit of it. What is the patient's best interest, or what is the patient's view on it? That's where these concepts of ideas, concerns, and expectations come in when you take a patient's history or during your consult. You need to find what the patient's interest is. You really need to ask the patient, what are you worried about? What is your fear? And if you get to that, I can tell you it's much easier. He might be just there for a sick note, but it's important for you to know it because you can work around it then. I'm not saying then you can ignore the medical aspect of it, but you really need to find out what the patient's main interest is. Now, that doesn't really mean the patient gets what they want if it is not scientifically correct. That's where the concept of patient satisfaction differs from patient-centered care. We were having this similar discussion at the fellowship today about, you have a lot of patients who come and say, I need IV fluids. Now, what's easiest for you is, oh, it's just a fluid, it's not going to do anything, or at least think that it's not going to do anything. Give the patient the fluid. Or that patient who asks you for an antibiotic for a common cold. It's time saving, it's much easier for you, and it's less stressful for you, less work for you to prescribe that antibiotic or fluid. But that is not the right thing to do. But then what can we do is tell him no, but that's going to be difficult. So how do you do it? And that is the skill where it comes to sort of, persuasion. Tell the patient, find out what the patient's true interest is. Why do they actually want it? What are they worried about? If someone is asking for a CT scan, what are they worried about? What do they want to see if they've got or not? Like if they're worried about cancer, then you work around, tell him why you don't think he's got cancer if that's what you feel. Now, and it is important because if it's known that institutions which has chased patient satisfaction more than patient-centered care, the patient outcomes were worse. If you just want that smiley face ticked on the patient feedback form, it doesn't really mean your patient outcomes are better. They've even been shown to be worse as compared to other places where patient-centered care was a focus. Now, so once you have your patient's interest, once you know your patient's interest, it's much easier to explain to the patient, come to an agreement with what you're going to do with them or what you're going to do for them. Right, so just now, how do we do it? Now, communication, it involves a lot of things. Like, for example, if you want to make a point to the patient, it depends upon what you say, how you say it, what you do while you say it. These are the three main things, so these are the variables which you can actually change. But there are other variables like how you look, and there are other things like your authority. For example, if a nurse saying something to a patient and then you go and say you're the doctor or your consultant, that's more effective. But those other things have some effect, but you can't change much about it. What you can really change is your verbal, nonverbal, and paraverbal communications. The paraverbal is how you say it, it's your tone, it's sort of how much you listen, how much chance you give them to sort of explain their views, and then you feedback them. And what you say actually has only a 7% effect on how effective your communication is. 55% is your nonverbal communication, and 38% is how you say it or your paraverbal communications. So, common things again, like I said, greet the patient, know what their name is, call them by their name if that is culturally acceptable, or say shake something or Mr. So just greet them by their name, it's more effective. And then obviously tell them who you are, what your intention is. The second point there is sharing your mental model. What that means is you tell the patient what is going through your mind about that patient's care. Give them as much information as possible upfront. If you have a patient who comes with a classic chest pain, and you know at that point you're not going to discharge him without your second set of troponin, tell him that you're going to be here for 6 to 7 hours. Tell him you're going to do a blood test now, you're going to repeat that blood test later. So give that information upfront. So then be empathetic. And then the next one is normalizing experience. That becomes important when, for example, you have a patient who's embarrassed about it. Tell them you've seen it many times. Someone who's coming with like maybe a sexual history, a sexual disease. Say, you're not alone. You've seen it. It makes it easier for them. Nonverbal communications. It's your posture. It's smiling, sitting at the eye level. Some of these are difficult for our emergency department. But again, sometimes when you have a conflict, it's probably worth sitting them down, sitting at there, and having that eye contact. Again, how you look, that's something you can change. Make sure you look professional in every way. Have that open posture, appropriate eye contact. So, and finally, I had to include discharge because that's not something which you're going to cover in our stations. Now, our discharge advice, generally, even on the Western literature, people don't understand 1/3. And I think it's worse for us. I think probably only 1/3 of our patients understand what actually we tell them. So how can we improve it? You repeat it. You ask them to repeat it back to you. Now, there's a question, verbal versus non-verbal. What do you think is better? Oh, sorry, verbal versus written. Written? No, if you had to choose one. Written? No, it's verbal. The verbal works better. Hardly people read what you give them, especially if it's a long. And then uncertainty principles. With that, I'll stop. Uncertainty principles is if you are not sure about a patient's out, like for example, if you're not sure, you still could have cardiac problem, but everything on your examination, everything on your investigation says that it's fit for discharge. Tell that to the patient. It's very unlikely you got it, but I can't be 100% sure. But if you have any of these problems, it still means that you got to come back as an emergency. With that, I stop and I'll let Dr. Ray start.
Thank you. So next, I'd like to invite Dr. Kumar.